There are many clinical conditions where treatment is more important than the diagnosis, where surgery is only half the answer. Emergent surgery may be required even before a clinical diagnosis is established to save life or to relieve severe pain. We present two cases operated in the last 4 days where we face this dilemma. The first patient is Mr. SS, a 50-year-old male who was brought to the emergency room with deteriorating sensorium, seizures, and vomits. He was intubated because of low GCS. On examination, his right pupil was found to be dilated and not reacting to light. The left pupil was also large but sluggishly reacting. He had left hemiplegia. In past history, he had a cerebrovascular accident earlier and was on dual antiplatelets for the same. This is a CT scan of the patient showing massive cerebral edema with its nodal or focal point in the right temporal lobe. There was a midline shift of 15 millimeters, and with a dilated pupil and low GCS, emergent decompressive surgery was considered mandatory. Fortunately, we had with us an MRI which was done for the same patient in January, which excluded any mass lesion, infarct, or bleed. Patient underwent emergent decompressive craniectomy midnight of 19th 20th March. This was followed by anti-edema measures. Post-operatively, he was ventilated, weaned off, and extubated on 22nd March. Even now, the right pupil is still dilated, left pupil is reactive and sluggishly reacting. There is left upper limb weakness. The patient was initially confused after extubation but is now well oriented. Post-operative CT shows that the midline shift has come down from 15 mm to 5 mm. There is a subcutaneous hematoma which can be attributed to the antiplatelets and to the midnight surgery. The second patient is Mr. SPH, a 55-year-old male. He is a karate instructor by profession and has been a trainer for 18 years. He presented with severe spasms of low backache, provoked by trivial movement. This has confined him to bed, and it is impossible for him to even turn around in bed. He gets spasms of pain on deep breathing or even when talking on a mobile phone. On examination, he was found to be bedbound, but there was no neurological deficit elicitable. The ESR was 77. MRI of the lumbosacral spine showed edema of the end plates of L5 and S1 vertebrae. He was started on antibiotics, injectable antibiotics, including ceftriaxone 2 gram twice a day and vancomycin. However, he did not tolerate vancomycin and we had to switch to linezolid. After 3 days, the pain was incapacitating and the patient requested that something be done. So he was taken for a pedicle screw stabilization of L5 to S1. A disc biopsy was also done and the reports are awaited. Post-operatively, there has been marked relief of the pain spasms. However, the ESR is still high and the patient has now been ambulated out. He is ambulated with a corset. This is the post-operative X-ray. The reason why we present these two cases is that there are many conditions where you can relieve an emergency by a surgical procedure even without having a confirmed diagnosis of the cause. The cause of malignant brain edema in the first case has not yet been established, and we will be working him up for that. The cause of the disc space inflammation is also not known. Biopsy is awaited. He is on antibiotics.